Hey, there
Okay.
you go. All right. All right. Well, I guess you guys ready?
Mhm.
All right, cool. Just let's see. All right. Well, good afternoon, everyone. This is Brandon Garrett, the National Minority Equality Forum. Just welcome to our weekly Friday webinar. I'm really excited about this webinar, which I guess we'll be co-hosting today, and with two of my favorite peoples. One of my favorite, I can't say favorite because I have a lot, but one of my favorite Xavierites, Tiffany West, and one of my favorite folks from West Virginia, Joyce Larkin. So great to have you both here with us today. We're going to be talking about bringing healthcare to your community, and these ladies have led some great projects that I want them to discuss for you. But before I get to that, I just want to have two announcements. One, our 40 under 40 applications are available online, so I'll put the link in our chat. So if you have anyone that you know, please share it with them and have them apply for our 40 under 40. This will be our 8th class. So we started this in 2016. So we're looking forward to is that seven or eight class? Yeah, counting. And then 2, our summit, they will be honored at our annual summit on health disparities. It's our 21st year doing the summit, and it's going to be April 17th and 18th during Minority Health Month. And so that's that on like what we have upcoming a couple of months from now. But now I just want to get into this discussion, and I want to let you have all the bios, you saw it on the website, but I'm going to start off with Joyce, and I just want to start off with what brought you here today. What brings you here today?
Well, good afternoon, Brandon. Good afternoon, Tiffany, and good afternoon to the entire NMQF family. What brings me to today's call is a level of excitement about the work that's underway. I understand that our work in the midst of COVID, other things that have been going on, has caused us to not pause, but to be challenged with how we work, how we serve communities, and how we continue to focus on health equity and health outcomes. So for me, I'm glad to be a part of the call, to hear from Tiffany, to offer advice and suggestions to the audience, and again, to reconnect and see where there are areas of alignment and strategy. So again, on behalf of Centene, thank you for the opportunity.
And then you, Miss West, what brings you here today?
I'm a passionate health equity warrior. I'm really excited about my new role at Gilead as the Senior Director of Advancing Health and Black Equity. I feel like it's an honor for a company like Gilead to have a title where we're unapologetically Black in our communication about our commitment to health equity, with our ability to lead transformative work in community, as well as the leadership from our CEO, Dan O'Day. Gilead is a Fortune 100 biopharmaceutical company, and for them to commit with their resources and with their leadership to advancing health and Black equity in communities around the world, I'm fortunate to get up every day and be excited about the work that we're leading.
All right. Well, and then speaking of some of their work, the reason I want to bring you both here is because you guys, more than anything, NMQF has been sort of a very data-centric organization, and we haven't gotten the opportunity to go in community. And more recently, I think with working with both your organizations, we've been able to go in, either doing community health clinics or HBCU tours and things like that. So I'm just going to continue with Tiffany, and I want you to tell me a little bit about your programming that you did at the end of in the fall and winter last year.
Absolutely. You know, the Advancing Health and Black Equity team is about a year and a half old, and I thought it was really important for us to establish, what does Gilead stand for in the health equity space? And so we have 4 pillars. The first pillar is brand and reputation. We need to demonstrate as a company that we care about Black people and Black patients. Most pharmaceutical companies are very patient focused, intentionally. That's our goal, is to ensure that we're bringing life-saving therapeutics to people all over the world. But I think with our team advancing health and Black equity, it's important for us to also center Gilead and community, and to ensure that our commitments are clearly stated and that we have resources behind those. So definitely, first pillar is brand and reputation. The second pillar is business impact. In our industry, clinical trial diversity is a huge challenge. The FDA is now saying that if your trials aren't diverse, that your drugs won't be approved. but we need to center clinical trial diversity in our history of medical distrust and medical racism. And we need to call that out, and we need to be centered in spaces where we can co-create programming that also serves our business interests. And so how are we diversifying our workforce? How are we identifying principal investigators of color? How are we supporting historically Black colleges and universities? How are we supporting clinicians who are practicing in underrepresented and underserved communities? So really focusing our business on that. And then third is transformative giving through the Racial Equity Community Impact Fund and the Gilead Foundation. We have historically committed to therapeutic area giving, but we've made unprecedented commitments to racial equity, social justice, and economic empowerment through our foundation and through non-therapeutic area giving, and we're really proud of that. And then finally, strategic partnerships. And I think it's important for us to partner not only with organizations that we've historically partnered with that are focused on HIV and focused on virology and now focused on cancer, but we need to also have partnerships with Black organizations, like organizations that are Black led and organizations that are Black serving, like the Divide Nine, like the Links. As a proud HBCU graduate, I wanted to make sure that we with our first programming did something that was highly visible and highly impactful. And so we did a historic, we called it the Gilead HBCU Roadshow. And in 3 months, we went to 11 HBCUs in 9 cities. And we didn't go just with activation and a party, we went with programming. So we did Healthy Sexual, which is really critical to empowering young people around their sexual health. We know that a lot of students are coming from abstinence-only programming in their schools. We know that historically, the Black community is very conservative when talking about sexual health. And so what we found is that young people were hungry for the information that we provided. Second was career journey. We had over 120 volunteers from Gilead talk about their journey into the pharmaceutical industry. And we feel like this is a pathway for economic empowerment for young Black people. A lot of students did not know that that was a career path for them. And so I was very passionate about ensuring that they saw themselves in our executive leaders and in our employee leaders, and to develop the next pipeline of leaders in this industry. And then finally, we had our activation on the yard, which I thought was really important for Gilead to be highly visible, so that again, we are able to say that we weren't there just for the football games or the basketball games, but our team of volunteers fully engaged with students for 4 days. We met with the presidents of schools to see what there were partnership opportunities. We want to make sure that we position HBCUs in a asset-based mindset, that we're not just offering a donation or a check, but we are looking for strategic partnership with these organizations.
Mm-hmm. Well, thanks for that, and thanks for all the work you did. I was privileged enough to participate in one of the totality of the programs at Xavier's during their homecoming, and they were very effective, and I think the students all enjoyed it. Joyce, and we actually got to work together a couple of times at Xavier in New Orleans, but a few other places as well during community health clinics. Could you tell me about your work with community health clinics and what the goal there and how you guys put them on?
I'd be happy to. Let me step back for a minute for those of you who are new to this type of call or new to NMQF, a brief description of Centene. And the name may not be as familiar to you, and I'll tell you in a minute why, but we are the largest Medicaid managed care organization. So we serve about 26.5 million individuals across the nation who are enrolled in a Medicaid program. Roughly that's 1 in 15 individuals. We're also the #1 or the largest carrier or participant in the marketplace product or Obamacare across the nation. And we also lead the nation in serving individuals with long-term care services and supports. So whether you're looking at California, Texas, New York, all of those larger states, we are there providing those services. In Texas, we're known as Superior Healthcare. In Florida, we're known as Sunshine Healthcare, and we are intentionally local when we think about our names and when we think about how we serve individuals across the nation. We have staff in all of those markets, in all of those communities. We hire from the communities. Our philosophy is we focus on individuals, we focus on whole health, and like Tiffany, we also focus on active local involvement. One of the things we liked about the invitation that we received from the National Minority Quality Forum a number of years ago to host community health clinics in communities. The goal of those clinics were to focus keenly on what the issues were in that community and to bring resources to bear. So when you envision a community health clinic, you often think about the blood pressure, the vision, the dental screening, the nutrition, mental health, dietitians. But what we found that was missing is connecting individuals to medical homes, utilizing the data to find out the health issues that we really needed to keenly focus on. And then something that Tiffany mentioned, being keenly aware of the need to provide communities of color with providers, with health experts, with advocates who look like them in this challenge. So that's what we've brought to all of the community health clinics that we've been able to host with the National Minority Quality Forum. We also found that some of the community organizations were trying to pull together maybe 50 or 100 people. But by working with the local housing authorities, by working with our local urban leagues, by working with our fraternities, our sororities, our churches, we've been able to gather 1,000, 1,300 individuals together for community health clinics in New York, in Michigan, in California, in New Orleans. Not only have we connected individuals with health homes, but we've also been able to interest individuals in participating in clinical trials, including a clinical trial that looks at COVID and its impact on communities of color. What I like about the Minority Quality Forum is that we get an opportunity to follow the data. So when Brandon came to us late last year and talked about Flint, Michigan, and the increase that they're seeing in certain types of cancer, and although they're not a cancer cluster as of yet, it gave us the idea to come together with a large scale community education and activation around cancer. And that's what we did a couple of weeks ago. We not only provided the screening, brought in the experts and brought the community out, but for individuals who are going to need additional screening and care, we are creating partnerships so that they have an escort, they have help getting to the doctors, getting to those next steps. And they have the funding that's in place so that additional screening, additional work is needed. We're there to help. So we too are pleased that when we look at our providers, they look like the communities that we serve. We're keenly aware of the shortages that we have in providers as it relates to community of color, whether it's mental health, whether it's child and maternal health. And those are things that we're interested in working with you, Brandon, going forward as we look at recruitment, as we look at engagement, and even as we engage elected officials and partners on what we can do to address some of the workforce shortages that we're seeing in healthcare.
Mm-hmm. Well, there's a good number, a lot of Black woman magic on this call. So I'm just gonna keep going in with the questions. One of the things you both mentioned that you're both from very like large Fortune 100, Fortune 200 organizations, but you still make certain that you go as, you go as local and as possible. How does, John Q. Citizen, John Q. Public, or John Q. Small nonprofit organization, reach out to you, work with you? This, like I said, these are huge organizations. So how do I get to you? How do I let you know that I would likely like to learn more about, sexual health or, cancer in my community, that type of thing?
Well, Gilead has a workforce of over 16,000 people worldwide, and we have an amazing local healthcare workforce, whether it's in HIV, oncology, hepatitis, COVID. We go local. Even though we're a large company, we have local teams that aren't just our sales force, but our community liaisons. They our health education workforce. We partner with over 400 small organizations through our corporate giving and philanthropy organization. And we are expanding our partnerships to include non-therapeutic areas. I had a call yesterday with the young man who has a patient navigation tech startup. And so I'm interested in, not only interested, but passionate about our commitment to supplier diversity, to make sure that we are bringing on BIPOC voices, vendors, as well as our commitment to our leadership. I always give out my email address, tiffany.west@gilead.com, and I try to direct people into the right space. But our work is done through local partnerships, through our collaboration with federally qualified health centers, community-based organizations. We couldn't do that, the work that we do, without those local partners.
Okay. Thanks, ma'am. Joyce, you have anything to add or?
Sure. Again, for your audience, they can go to centene.com, CENTENE.com. There they can trace us to our local health plans and make connections there. We have a group that leads strategic partnerships and alliances. We do that on a national basis, but we do it on a local basis as well. I'm also fortunate to head up our Centene Foundation. We're in the process of revamping our foundation and reestablishing our goals and our objectives, but we're keenly focused on impacting local communities. So we've been making some significant grants to organizations in local communities, not-for-profits, whether that be responding to the events in Uvalde, Texas, responding to the need for health service in rural areas like Nebraska, or even down in Georgia, where we are working very closely with the City of Refuge in Atlanta. But we're just getting started with the refocus of our foundation to be very, very, very local. I'd be happy to talk with anyone that has an interest in working with us. And my email is jlarkin@centene.com.
All right.
And I really would like to say that, for the Urban League affiliates, for the churches that are out there, for the community health centers, I'm like Tiffany. We are grateful to partner, to work closely with you, and quite frankly, couldn't do our work without you. So looking forward to working with you going forward.
No, and I really appreciate you both. I mean, just for a background, both Centene and Gilead were our most recent outstanding large organizations of the year, just because of the amount of work they do within community. And so I just want to give them another shout out for that. One of the things that sort of drew us to working with both of you guys is that when we met, our board meets periodically, but the thing they always, and then when I first joined NMCF, spoke about was that we weren't in community and we weren't out there. Like, we had all this data, so what are you really doing it? And Dr. Puckerin's thing is always, we're the statisticians at the baseball game. We can help physicians and other clinicians in general do better at their job, just given the data. But our board encouraged us to go work a little bit more and get out there more. So we reached out to you guys, and you guys have been amazing. Since you've been doing this work for a long period of time, what did you notice that you were surprised by when you actually went out in community? Like, we always hear like you need to be out and doing X, Y, Z, but what did you learn, and what other needs did you notice that you weren't aware of before you actually stepped foot in the community?
Brandon, if I could mention, I think what surprised me about community is that there are individuals and organizations in each community that we visited. They've been working on stubborn health issues for decades, and they really have been doing great work. What they've lacked is the additional resources that might be needed to take that work to the next level. The other piece that's missing is one that you mentioned, and that's the data. For all of our work around policy, legislation, and advocacy, the data matters. So we're taking that data to local Medicaid directors. We're taking that data to state budget directors. We're taking that data to governors to point out where we need to focus our work in health, where we need to be concerned about health equity, and where we need to leverage technology and really advance healthcare delivery. But I'm incredibly impressed with the work that's been underway locally. I am also very, very impressed with the commitment of our providers of color when we have tried to institute changes, maybe in maternal and child health with the doulas coming on board, or asking providers about changing their hours to support community-based clinics and school-based clinics. The response that we're receiving is a resounding, we're in the community and we're happy to do it.
I couldn't agree with Joyce more as far as the need for additional resources to scale up the work and passion that is already happening in the health equity space. I think what I'm most surprised about, not necessarily about what's happening in community, but I think the perception of leaders about what's happening in community. And I think it's important for us to be a bridge to what I call kind of indoor cats. People, our executive leaders need to get out in community so that they can actually see what's happening. They can change their perspectives. They are passionate about health equity, but they also lack the lived experience of people that we're trying to serve. And so I think it's really critical for in our roles to ensure that decision makers and thought leaders internal to our companies are also connected with decision makers and implementers in community in a real and meaningful way, so that they can be educated and informed as they're making resource allocation decisions, as they're making decisions about our business. It's really important that we have an environment and culture of co-creation on solutions to community. And so I think that was the most surprising part. I think for us and on our health equity team, our goal really this year is to do more around bringing Gilead into communities in meaningful ways. Like for example, our media buys in Black media are very low, almost it's a very small percentage. As I go and talk to large advocacy organizations that aren't Black led, they expect patients to go to their websites and get their resources. And so I think it's really important for us we talk about bringing community and engaging with community, but we need to be able to do that in a more strategic and meaningful way as people are digesting and consuming information differently than before. A TV ad buy may not be the right way to communicate with audiences where most people spend 5 to 6 hours on social media every day now. And so how are we using analytics to do better targeting of information to Black and brown audiences and community, specifically health information? I read an article around maternal and child health and doulas who are reducing maternal child health in Black communities. And one of the young women who just gave birth, I get a majority of my information on my health from TikTok. So again, I think trying to figure out from our vantage point, if we are serious about health equity, how are we being an agile organization and pivoting to meet the patient needs? So, I'm just surprised every day by the thoughts that Black and brown people are a monolith, and that we need to be agile in our targeting, in our communication, our messengers and our messages.
And Brandon and
Go ahead.
Tiffany, the work of the Congressional Tri-Caucus has been consistent and strong in the area of health, education, and other matters impacting our community. And Brandon, whatever information those members need, they've been with us at the health events. They've been with us on the advocacy visits. So whatever information the Tri-Caucus needs to advance the cause, all of us stand ready to help provide that. And Tiffany, it's interesting that you mentioned maternal and child health. Thanks to NMQF, we're going to host a Hill Roundtable on that exact topic in just a few weeks. And so we're looking forward to taking a look at the data and seeing if there are ways that Tri-Caucus members and of course our community partners can help address that.
Absolutely.
So I noticed one thing that we're obviously at the beginning of in February now, but we're still at the beginning of a new year. What are some of your, I guess, programming goals for the upcoming year that you want to sort of highlight? And if you like, maybe even your goals for this year, and then like what you wish you could do or would the ideal.
In talking and doing our focus groups, key informant interviews, thought leader interviews, I think specifically in the breast cancer space, there's this discussion and talk around health literacy and patient literacy, which is really important. But I also think when 2023, we really want to plant a flag in this concept of patient agency and medical distrust and medical misinformation. And so we had an amazing panel internal to the company that we're going to take external with some media partners, but it really was focused on the different pathways and experiences of white breast cancer patients and Black breast cancer patients. And one of our panelists was a Black woman who's a PharmD. She's the head of our global advocacy organization. And her challenge is not health literacy. She's a clinician. And she talked about her horrible journey through her reconstructive surgery and how she went to the doctor 4 times and they didn't believe her and she kept going home until she was septic. And so that is not patient or health literacy, that is patient agency, and that is the healthcare system not listening to people. And so how are we putting just as much emphasis on how healthcare systems treat Black and brown people as we put on patient literacy, which is critically important. So I think that's really a 2-year strategy that we want to focus in on. I think the third piece I mentioned is really how are we activating our messages and our brand in spaces that are important to Black people. And so that's not only the Aspen Ideas Summit, that's not only our partnerships with NMQF, where we can have thought leadership, but that is also going to Afrotech and Afropunk and Essence and women of power, engaging with women like Sarah Jakes, engaging Mary J, like different thought leaders like Mary J. Blige, and having a strong influencer strategy so that we can reach people with our messages. And so really how as a pharmaceutical company can we message differently around health to Black and brown communities? So I'm really excited about some of the ideas that and some of the activities that we'll be implementing in 2023. And then again in 2024, I think this idea around how are we ensuring that we are moving cultural humility into healthcare systems is something that we really want to focus in on. The pharmaceutical companies, we have like 5 or 6 touches probably every day with large healthcare systems. If you think about the different therapeutic areas, if you think about the sales force, if you think about medical scientists who are educating doctors, if you think about community liaisons who are doing community programming with patients, we're an industry that has multiple touches. And so how are we bringing conversations about cultural humility and the role of the healthcare system directly to the healthcare system to ensure that we're improving patient outcomes? And that's more of a long-term strategy to address health equity.
All right. Have anything to add, Joyce, or?
Sure. From a Centene perspective, our areas of focus as it relates to health is based on, what we're seeing that we need with the programs that we serve and the individuals that we serve. So no surprise that workforce development is very high on our list, trying to work with community colleges and partners and others to create a strategy for building the workforce for the future. The second bucket is maternal and child health, which I mentioned previously. How do we improve health outcomes for newborns and also make sure the moms have support as they go through the early years of the baby's life? And last but not least, and equally important, Brandon, is a conversation we started at our last NMF conference, and that is mental health. That is a huge issue. It can't be solved overnight, but we're committed and we're starting to work with the federal government and others, even around that 988 hotline, while we look at other strategies for mental health. In addition to those 3 areas of health, we're keenly focused over the next year or so. I mentioned earlier, revamping our foundation and being very intentionally local as we work on new grants for communities and in support of communities. And then the last thing is just an increased level of coordination around our legislative policy and advocacy agenda to make sure that if we're meeting with governors, our partners are doing the same thing. If we're sharing data, our partners have the opportunity to do the same thing so that there's more coordination around our common health goals and health strategies.
Thank you for that. Now, one thing I noticed about not only what you just mentioned, but also that what you guys seem to do naturally is that you work to meet people where they are. So you didn't say, we're going to have this event, 30 miles away from you guys. We're going to do it right here, either on the campus or in the area. You're very seem to be the focus is like meeting people where they are. And I'm wondering what, as you do that, what has been most beneficial about sort of meeting people where they are and learning from them that way versus, like you mentioned, Tiffany, having them, they'll say, oh, come meet us over here or get on this website or whatever. Like, how do you make it more comfortable for folks and both online and then in the community?
I mean, I think
we have over 80,000 employees and they're hired from those local communities. So it's natural for us to meet people where they are because that's where we are. Whether it's our office buildings, whether it's our call centers, whether it's our outreach workers, our community workers, they're working right in the communities where they live. They're working in the communities where they grew up. And so for us, it's natural to position ourselves where the need is because that's where we started our base operations from. And we're grateful for the local hospitals, the rural hospitals, those local community health centers that are right there with us, providing the services and helping us identify what those additional needs are.
All right.
Just to add, I think it's important that we, as we think about co-creating solutions on health equity, we have to meet people where they live, work, and seek healthcare. Those census tracts, neighborhood by neighborhood, could be completely different. I think there's a stat that a majority of Black people live in like 2,600 zip codes across the country. And so we need to ensure that if we're going to make a significant dent in health disparities, that we are very locally focused on issues and challenges that people are facing every day. And that could be things related to the social determinants of health, like transportation, food deserts, medical deserts, into things that are really complex, like medical mistrust and distrust, bad experiences, and lack of education on how to empower yourself in your own health. A majority, I think, of negative health outcomes that we're seeing now have to do with violence. People can't go to the park and exercise because there's violence in their neighborhoods. They can't go to the grocery store because they don't exist and it's too dangerous to walk or take the bus to get fresh fruits and vegetables. So these are societal challenges that as a company, we can't expect people to get on our therapies if they can't even live a safe and healthy lifestyle. And so I think it's important for us to think much bigger around how we address health disparities and inequities. We have our amazing partnership with your team, Brandon, at NMQF, to do some of these larger societal challenges related to policy and healthcare access. But we also are investing hundreds of millions of dollars into schools and education. And so I think that's a very localized and targeted interventions, and that we know for a fact that we understand where we have high rates and high prevalence of disease that we're trying to address. So I think, we have to have localized strategies. We have to have localized partners, as well as localized thought leaders to help us co-create some of these solutions.
Yeah, and your stat was right on point that about 75% of minorities in general all live clustered in a little less than 3,000 zip codes. So we were still sort of pack mentality, maybe. One of the things that Dr. Puckrin always mentions, at least as of late, is just reimagining the entire healthcare system. Like, if you blew it up and had to start all over again, what would be the best to help what would be the best way to help the most vulnerable. So if you're thinking of healthcare not under the current confined construct that it's under, if you could think, I want to build a healthy community, what would it, if you had to reimagine healthcare yourself, what would that look like? What are some things that need to be done? Yeah.
I think that from a Centene perspective, it has to involve advanced technology systems and tools. Because again, healthcare gets driven by the data. The data has got to be real time, and it's got to be sensitive, and it's got to be transmittable. It's got to be readable. And so for those that study data, imagine when you're receiving outdated, antiquated, or you're receiving outdated data coming in through antiquated systems, and you're trying to figure out how do you make it available, readable, so that we can act on it. So there's no doubt there's a need for technology, advanced technology, systems, and tools. The other thing that we found interesting is that, sometimes in the commercial world, you're able to offer incentives for healthy living. Those incentives weren't available inside of the Medicaid program in particular, and now those incentives are coming into play. We are seeing that members are responding if we ask them about joining healthy lifestyles, healthy programs like Start Smart for your baby, where an individual can be encouraged to take the child in for the well child visits, to make all of those vaccination milestones. So we're seeing just in the commercial world how it's being adopted, that it's being adopted when we offer it from this standpoint as well. And then again, just meeting people where they are. How can we serve? How can we meet the workforce challenge and make sure that there are community health centers, but as Tiffany mentioned, as well as healthy grocery stores and all the other things that makes a community thrive, available in communities across the nation. And I believe we can get there. Centene believes we can get there.
I think for us, we have a macro and a micro view of the healthcare system. I think from a macro standpoint, we are investing, for example, in disrupting the school to prison pipeline and educational equity. We're investing last year $20 million in educational equity with a $200 million commitment. Because we know if you have better educational outcomes, you have better economic outcomes, which we hope will lead to better health outcomes. But we also know that from a micro level that specifically Black and Brown people, we still, even if we have similar or the same income, we still are, we still have worse health outcomes than other white people who have the same income stratus as we do. So again, I think for us, how are we influencing the practice of culturally competent and culturally humble care for all people, so that your experience at the doctor, my experience at the doctor is equitable to the experience of people who don't look like us. And so I think those are some of the other things that we're working on from our medical scientists and to our community liaison standpoint, as far as really expanding this conversation around cultural humility. And are you treating your patients equitably? Are your patients equipped to be able to say, hey, wait a minute, I have some questions. Are you empowered enough? And so we're working with a lot of organizations who are working in that space. We provide therapies for HIV. And so we're also, from a policy perspective, focused on issues like decriminalization and stigma in the healthcare system. From a policy perspective, we know that, for example, in Tennessee, they're giving back all their HIV prevention money to the Centers for Disease Control because they don't believe in healthcare for transgender patients. And so, to me, healthcare, I'm an epidemiologist and a public health person. I think for me, we have to address the entire social ecologic model, not only the patients and the healthcare system, but the schools and the systems that lead to inequitable health outcomes and health disparities. And I'm proud that our company has such a broad view of how we address health disparities. Is not necessarily just the patient and the provider, but really the entire community.
Wow, thanks for that. And I invite audience, if you have any questions for our guests, We're about the 40 minutes in, so just put it in the Q&A or the chat. We'll make sure that we get those questions answered. But one of the things we talked about in the beginning of the program is moving the needle, like scaling it up. That what you notice in the most communities, that you can have a much healthier community if they had the resources to meet the challenges and the demand and the need. What other things do you think can be done to help move the needle in health equity, to make things more equitable in the healthcare space?
I'm really excited that everyone's talking about health equity. Like, it's the hottest topic on, and all companies have someone or something or an interest to be in health equity space. I think for me, one of the things that we're working on this year is like a health equity summit at Gilead, where we're bringing in industry partners, because we need to have economies of scale. We all should be at least rowing in a similar direction, so that we are all investing, for example, in historically Black colleges and universities. This is a flush time for HBCUs as far as different companies wanting to partner. But when I talk to HBCU presidents, their institutional advancement staffs are the same size. And so how are we providing technical assistance to these institutions so that they can leverage those dollars and resources for the foreseeable future? I know Xavier is launching a medical school. Morgan State is launching a medical school in Maryland. And so I think for me, when you want to get to economies of scale, it's really important for companies not just to write a check, but also to be in a partnership mind frame, so that we can really invest in historic institutions and organizations, whether it's HBCUs or other Black organizations, so that we're able to have lasting change. I think there was an article when I first came on in this position at Gilead about the $40 billion commitment after George Floyd, and where's all the money gone, and have those commitments been met? And so I think it's really important for us to understand that resources are fantastic and great, but we need to be in a partnership mindset with organizations and institutions if we want to address health disparities, because that is a long-term goal. It can't just be a short-term commitment, but a long-term strategy over decades.
Thank you. Joyce, anything to add there?
Sure. For Centene and addressing health equity, the word is workforce. Where are we going to find the future workforce? How will we recruit and attract and retain them? And then what age do we need to start out? And, keeping in mind the enormous amount of debt that individuals have when they complete medical school. Do we need to offer incentives at the state level? What do we need to do with community colleges? What incentives do we need to offer for individuals to stay in the communities? And then when we start to look at communities of color and rural communities, we want to make sure that those practices are high quality. Centene was one of the first to create almost like a physician model, where in some of our markets, there are physician groups who have a vested investment in the health programs or the health business that we set up. And to some degree, it means you don't have to go out and find your own building and open your own practice. You can start by practicing with the provider that's already in your market. So we'll look to see if those types of models work. And Tiffany, looking at HBCUs, how can we get inside those doors and start working with especially the students who are at HBCU medical schools about practicing right there where they lived, where they grew up. But the workforce shortage is real. And so we're going to be devoting a lot of effort to trying to address that issue. Brandon, with your group, with Tiffany, with the NMA and other health professionals.
Yeah, and one thing, appreciate that. And then one thing, at NMQF, we typically work a lot with both the, obviously the companies, the researchers, the physicians, the payers, et cetera, but we also work with the policymakers as well. And I know a lot of times that public policy, or the lack of public policy, drives health equity or health inequities. What are some, I think, just public policy changes that you would say that if you could change like something that's happening or that government's doing or hasn't done or could mandate that would make things better for community health?
I think one issue that we're working on is reimbursement for all patient navigation. Again, I think just myself, I actually pay for a patient navigator through, my bougie health insurance because navigating the healthcare system is extraordinarily difficult. And I don't have like cancer or chronic disease just to keep up with my, middle-aged woman trying to be healthy visits. So I think just making sure that everyone has equitable tools in order to navigate the healthcare system. People can't necessarily afford, my healthcare navigator that I pay for at like One Medical. And so I think that's something that is critically important. I think we should try and think about not only enrollment in clinical trials, but how do you maintain people in clinical trials who are Black, specifically, and Latino and other underserved populations. If you have to do a cancer trial and 30 rounds of chemo and sit in a chair for 4 or 5 hours, it's very difficult for you to navigate your everyday life. And so what other resources can we provide from a policy perspective for people who are suffering from chronic conditions that require constant and frequent engagement in the healthcare system? Those are the differences that, those are life and death differences for people. And I think that if you have means, you have a prolonged life because you have the ability to maybe take FMLA or unpaid medical leave. Whereas, someone who works a 9 to 5 or a mom or a dad who are taking care of their children don't. So I think paid medical leave, paid family leave, those are larger issues that come before Congress every year that don't really move, but they have real life implications for people who work every day. So I think those are kind of some of the kind of wonky issues around patient navigation, and then just some of those quality of life issues like paid family leave or paid medical leave that are really important for communities of color.
Mhm. All right. And in addition, we have two questions. One, they'll ask how to reach you guys. So I just want to make sure you know that I put their email addresses. They've shared their email addresses in there in the chat. So you have any further questions for them directly, you can go there. Another question we have is, what do you think would facilitate healthcare to better address all social determinants of health that may be impacting any individual patient? So let's see if I can unpack that. What do you think? Yeah, so I guess how do you better address the social determinants of health and dealing with, I guess social determinants of health, the things that determine your health status, environment, background, culture, et cetera.
I'll let Joyce go first. It's a large question.
So we still have individuals who are falling outside of the healthcare system. And not all of those individuals, it shouldn't be that way. So we still have veterans who are entitled to VA services and support, but they're not enrolled yet. We still have states that have not opted into the Medicaid program yet. So some individuals don't get the benefit of even a program like Medicaid. So we need to make sure the programs that are in place, funded by the government, like the VA and those veteran services, are actually reaching individuals. If you look at states that have not expanded Medicaid, we do see where individuals that are enrolled in a Medicaid program are having healthier outcomes than individuals who are not. But then I think it goes back to working very closely in local communities with community-based organizations, using not only health navigators, but these community organizations to identify where are there gaps in services, in delivery, and what can we do to shore up things like our local food banks, if that's where individuals are receiving food, advocating for local healthy grocery stores, if that's something that's needed there in the community. And as Tiffany mentioned earlier, transportation, housing, those things are part of it as well. And someone will listen and say, well, that's the same thing we've been talking about. But the question is, when do we start to get even more intentional and partnering together even more closely to move the needle in this area? You know, we're starting to hear about a lot of government funding that's flowing into communities. We have to make sure that those dollars are being received by the community-based organizations that are prepared and have already been doing the work. And then how do we measure and report back to the government and back to Capitol Hill on the outcomes that we're seeing as a result of these investments?
I couldn't agree more. I think there has to be a broader topic and a broader conversation about care coordination. I think there's a desire for the clinician in their 15 minutes or an hour to make people healthier, where that's not possible. You have to think about the systems of care, and the systems of care need to include the community. Health systems are being consolidated. All the hospitals are consolidating into these large healthcare systems with 100,000, 200,000 people within a healthcare system. And so how are we really utilizing that kind of consolidation in the care system, as Joyce said, to leverage technology, to leverage care coordination within that system, but also connecting external to that system? And so again, those are the food banks, those are schools. How are we engaging in health literacy? How are we ensuring that the new kind of expanded, urgent care system is engaged with the larger healthcare systems? Healthcare is fragmented and it is very difficult to navigate. Health is fragmented. That is also very difficult to navigate, whether it's a gym or a park or a dietitian, like those things. If we want to improve health outcomes, you have to have a level of health literacy, a level of patient agency, like I'm going to speak up for myself, and then a level of healthcare coordination in order for patients to adequately move through all these fragmented systems. So I do think if we had kind of those three, if we focus on those three things to your patient, one is kind of systems based, then we can address the social determinants of health. Not one person or one entity is responsible for that. It is definitely the government, it's definitely our social systems, and it's definitely the individual and the healthcare system. And so I think that piece is very individualized, it's very localized. So there aren't really, one answer for all things, but I do think some emphasis on coordination, education, and agency would go a long way.
Mhm. All right.
And Brandon, I think Tiffany brings up a good point as it relates to physicians. We're asking physicians to do a lot. But a physician may see a patient for 4 different things, but only be paid for one encounter. So how do we incentivize? How do we reward physicians? But on the other side, when we look at training physicians for the new way we want to look at healthcare, how do we go into medical schools? And how do we make sure that that level of training and support is there? And of course, incentives that say, if you go back to an underserved or rural community, that, we're going to forgive some of your student loans, or we're going to provide housing subsidies. What can we do to help the physicians of today mentor the physicians of the future? And then what do we do to make sure there's a successful path for people that are interested in entering practice? We're seeing a lot of people also start to focus on the specialties, but where's your family provider? So those are areas that we need to be sensitive to and address as well.
Thanks for that. The pipeline is certainly important as well. I think we're just about at the hour, so I just want to invite you guys, if you have any closing remarks you'd like to share with our audience about bringing healthcare to the community, I'd love to hear them.
Well, first, thank you, Brandon, and thank you, Joyce. It was a pleasure to be on the panel today. And, I think for really focusing on bringing healthcare to the community, one of the things that I'm really passionate about and working with our team at Gilead on is volunteer, like a volunteer skills bank. You know, we like to stuff potatoes in bags and go to food banks. But what skills, we're very highly skilled people. How are we investing in community-based organizations to make sure that they're successful? You can invest and mentor executive leaders. On the HBCU tour, I gave out my cell phone number to about 20 different students. They all texted me and asked me for advice. So you can do things big and small to improve a lot of the issues that we talked about today, whether it's workforce development, whether it's growing and ensuring that community-based organizations, which are the linchpin to healthcare, are viable and thriving. And also, you know, lobbying and educating your legislator on things that are important to you and your community. Are you a part of your neighborhood association, your ANC? Are you demanding parks in neighborhoods where you may not live, but you see that there are issues and challenges for other people? And so healthcare is very complicated, but we all have a role to play in advocacy, as well as, you know, volunteerism. And those are things that we can do individually, as well as mentorship. You know, are you a part of your employee resource group and ensuring that your company is living up to their values as far as diversifying their pipeline? So there's a million things individuals could do. I think that we're in a moment in time that, you know, what we talk about amongst ourselves is that we're trying to make this a movement and not a moment. That requires us to all be rowing in the same direction around health and employment equity in this space.
All right. Joyce, you want to close this out?
Brandon, sure, I've appreciated Brandon sharing the time with both you and Tiffany, and appreciate all the great ideas, Tiffany, that you've had to offer, and Brandon, value the partnership with the National Minority Quality Forum. I think I'd just say in closing for Centene, we're hyper local. Looking forward to connecting with you in the communities where we are, working with you, serving on your boards, having you serve on ours, but collectively working together with you and other community partners to improve health outcomes for our communities.
Well, I think that really sort of your last two your both comments, the last minute or so, is really encapsulated. One is that healthcare is very complicated and we all have a role to play. And so definitely appreciate all of us working together, improving it. And then two, making everything hyper local to make certain that you know the needs of the folks. I just want to thank Ms. Joyce Larkin from Centene and Ms. Tiffany West from Gilead for all their work and their support. Again, their information is in the webinar chat, as well as mine. I shared my email address as well. And then finally, too, we look forward to seeing you next week, but also in April for our summit. So you guys have a good weekend. Okay, thanks.
Thanks, Brandon.
Thanks.